All right, so good evening, everyone. Thank you for joining in for the grand rounds today. I'm going to go ahead and share the screens so that you can get credits for the grand rounds. So for today's session, please text 20412, number 888-816-4893 as an SMS message. And the future code, the room code is future 2024. The link will be again displayed for the MOC credit. So again, step one, the CME credit and the MOC credit, both the links will be displayed back during the session. With that, I'm pleased to bring in today our speaker, Dr. Jakpreet Grewal. And joining Dr. Jakpreet Grewal is our panelist for today is Dr. Kenneth Delnawan. So Dr. Grewal joined us after completing his advanced heart failure and transplant cardiology from Medical University of South Carolina. We are very excited to have him here to start our pulmonary hypertension program in addition to his role in advanced heart failure program with cardiac transplant and LVAD. He did his medical school in Aruba and subsequently had internal medicine and residency at Drexel University School of Medicine, Hahnemann University Hospital. He subsequently had fellowship in cardiology at Nevat Beth Israel, and subsequently has joined us here. He has, when I spoke to his peers and his mentors in the school, they were very indicative of his extremely amicable nature, and clearly indicated his interest to be back in New Jersey. And the reason he was back is because his entire family is here. So we're really happy to have him back and have him help us develop the program. And so Jakpreet is going to talk to us about pulmonary hypertension, and subsequently we'll come back and have a panel discussion. Just to say that this is very timely because he is in league to develop the pulmonary hypertension program here. The pulmonary hypertension program is an extension from the advanced heart failure clinic, and to enable a multidisciplinary environment in which we will have people both from pulmonology and also rheumatology join in along with other personnel that are required. We have also an extension of that now in the CAP building. Very soon we will have it situated very close to where he's located in Plum 2, that is in the Plum 1, that is in the Plum 2, and the pulmonary hypertension clinic will be expanded there as well. So with that note, Jakpreet, we look forward to your presentation and we'll come back for a panel discussion.
Great. Thank you, Dr. Gupta, for the introduction. I'm going to go ahead and share my slides. Just let me know. Can everyone see my slides okay?
Yes.
Great. So I'll go ahead and get started. So today we're going to be talking about pulmonary hypertension. We'll discuss the updates and emerging therapies. I have no financial disclosures for this talk. The objectives of this talk are to discuss pulmonary vascular physiology. We'll discuss the updates in the classification of pulmonary hypertension and go through the diagnosis and pathophysiology of the different classes of pulmonary hypertension. And we'll also go over how treatment strategies differ among the different groups of PH. So as we all know, pulmonary hypertension refers to a group of diseases characterized by a pathologic elevation in mean pulmonary arterial pressure. This involves multiple clinical conditions varying from pulmonary vasculopathies, changes in cardiac or pulmonary parenchyma, and chronic thromboembolic disease. Management is complex and requires a multidisciplinary input from a wide array of specialties. And as we all know, the pulmonary hypertension is associated with increased morbidity and mortality. Here we'll review the classification groups of pulmonary hypertension. And I really like how this has been broken up into 5 groups. This helps us narrow down the pathologic component and the likelihood of response to therapy. Group 1 being pulmonary arterial hypertension, formerly known as primary PH. This can be further broken down into further subsets of idiopathic, heritable, associated with drugs and toxins, most notably methamphetamines, and PH associated with systemic illnesses. Then we have group 2 PH, which is the most common form of pulmonary hypertension that we see. And this can be attributed to any cause of increase in left atrial pressure. So whether it's heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, valvular disease, or any other structural abnormality. Then group 3 is PH associated with lung disease or hypoxia. We can break this down into hypoxic induced vasoconstriction. So we think about obesity, hypoventilation disorders, high altitude, or disorders of capillary bed loss, such as ILD and COPD. And then group 4 PH is pulmonary hypertension associated with pulmonary artery obstruction. So most commonly we think about disorders such as like CTEPH, chronic thromboembolic pulmonary hypertension. And then group 5 is more of like a miscellaneous group where we're not exactly sure about how treatment strategies should be applied in this group. When we talk about the definition of pulmonary hypertension, the original cutoff of a mean pulmonary pressure of 25 millimeter mercury was established at the first World Symposium of Pulmonary Hypertension. And this was done back in 1975. And this cutoff remained the benchmark for about 40 years, even until the time I was a trainee. And when this cutoff was reflected upon with expert opinion, this is really based off expert consensus and in the absence of sufficiently powered clinical data. At the 6th World Symposium of Pulmonary Hypertension, this definition was updated to 20 millimeter mercury. And most recently, the European Respiratory Society has updated this the PVR cutoff for pre and post capillary hypertension to 2 Wood units and has reintroduced the cutoff for exercise-induced pH. And compared to the previous definition of using an absolute cutoff of greater than 30 millimeter mercury, the current definition uses a mean pulmonary artery pressure over cardiac output slope, where we use a baseline and a set of values over a period of exercise stages. Coming up around the corner, we have the 7th World Symposium of Pulmonary Hypertension, so I look forward to any further updates in the classification of pulmonary hypertension. So this brings up question is, what is actually normal? If the first definition was based off expert consensus and in the absence of clinical data, we now have more data to support our cutoffs. So in 2009, Kovacs and his group reviewed 1,100 patients who underwent right heart catheterization. And these were healthy patients, and they established that the normal resting supine PA pressure was 14 millimeter mercury, give or take 3.3 millimeter mercury and plus or minus. So with 2 standard deviations, we get a cutoff of about 20 millimeter mercury, which is our new definition. And to further justify that, Dr. Marin and his group reviewed patients of a VA cohort who were referred for right heart catheterization. And these were patients with pulmonary hypertensions of all sorts, group 1, group 2, group 3, all sorts of pH. And what they're able to show is that there's a continuous mortality increase starting at 20 millimeter mercury, and even an inflection point in mortality at 2 Wood units of PVR. Even at mild pH cutoffs, pathogenic changes are observed in echocardiography and RV size and function. While these new values inform prognosis, it does not guide treatment, as all the previous therapeutic studies have been done with a mean pulmonary artery pressure cutoff of 25 and a PVR cutoff of 3 Wood units. So to summarize, our current pH definition is a mean pulmonary artery pressure greater than 20 millimeter mercury. The classification for precapillary pH is an elevated pulmonary pressure with a wedge pressure less than 15 millimeter mercury and an elevated PVR of 2 Wood units. And then when we talk about post-capillary pulmonary hypertension, we have isolated and combined pre- and post-capillary pulmonary hypertension, which both use a elevated wedge pressure, but the difference lies in the PVR. And the definition for exercise pH, which I mentioned earlier. So now we'll take a couple slides to talk about pulmonary vasculature. In the absence of a hemodynamically significant shunt, pulmonary and systemic circulation circulate the same blood volume. Pulmonary vasculature differs in that it is a low resistance circulation, about 1/6 of that of systemic circulation. The right ventricle requires about 1/5 of the energy required to circulate the same blood volume. Therefore, the right ventricle is a high volume, low pressure pump that requires efficient ventricular arterial coupling. And in count, the stiffness of large conduit vessels is lower, allowing to accommodate a large range of blood flow with little changes of pulmonary pressure. And to further conceptualize this, I like to use this principle that I learned as a trainee, where we take Ohm's law and translate that into cardiology, where pulmonary pressure equals cardiac output times PVR with the addition of left atrial pressure. And this helps me focusing on the pathologic component of patients with PH. So when I see a patient with PH and I look at different aspects, I can break it down. So if there's a PVR issue, I'm looking at vasculopathies, hypoxia, or obstruction. If there's an elevation in left atrial pressure, I'm thinking more about along the lines of cardiomyopathies or valvular diseases. Or if there's a high output state, I'm thinking about anemia, obesity, cirrhosis, or shunts. So it helps me really break down PH into 3 categories. And we can also translate this to systemic circulation as well, where we use the same cardiac output. Instead of PVR, use SVR, and with the addition of right atrial pressure. Here we'll talk about the differences in the right and left ventricle. Oftentimes, the right ventricle is viewed upon as a weaker right ventricle. And there are significant differences between the two. And here we have an animal model which simulates the sensitivity to afterload. Here we have a right ventricle with acute increases in afterload has a dramatic decrease in stroke volume, where over a larger afterload range, the left ventricle remains more resilient. And there are many differences between the left and right ventricle. For one, there's embryologic differences. There's morphologic characteristics where the left ventricle is a prolate ellipsoid, where the right ventricle has a crescentic form around the left ventricle. There's differences in the myocardial characteristics and the myocardial architecture that we see routinely on echocardiogram. And again, hammering down that point I made on the last slide, the left ventricle is a high pressure, high resistance pump, where the right ventricle is a low resistance, low capacitance pump. And on the next slide, I'll talk about the flow characteristics that are different in the right and left ventricle. So it wouldn't be hemodynamics talk if I didn't mention pressure volume loops. So we have 2 pressure volume loops here. On the left, we have a left ventricular pressure volume loop that we're quite familiar with. Here we have a diastolic filling phase, followed by an isovolumic contraction phase, followed by an ejection phase and isovolumic relaxation. If we look at the normal baseline right ventricular pressure volume loop, we do not have that isovolumic contraction or relaxation phase, and rather instead we have ejection right at the onset of systole. Now this changes when the right ventricle is exposed to high afterload states. Here we have another animal model where we have the baseline pressure volume loop. Then we have another animal model with pulmonary hypertension. As you see with afterload, the pressure volume loop assumes that rectangular pressure volume loop with a isovolumic relaxation and contraction phase. And with inhaled iloprost afterload reduction, we resume that near triangular shape in this model. And here's another example, a little bit of an older but cleaner pressure volume loop. We have a normal loop on the figure 1, whereas in figure 2, in figure 3, we have high afterload states, different pathologies, but again, we have that more rectangular, more well-defined periods of isovolumic contraction and relaxation. Moving along, we'll talk about the epidemiology of pulmonary hypertension. So patient estimates suggest that PH prevalence is about 1%, and group 2 PH is about 70% of all PH. So most of what the pulmonary hypertension that you see is related to group 2 left heart disease. And when we talk about pulmonary arterial hypertension, primary PH, this is less than 3% of all PH cases. And in that cohort, idiopathic PH takes up the bulk of that pathology. And this may be a little bit higher in different geographic locations due to methamphetamine use. Thankfully, in this area, we don't have too much of that. As far as presentation with pulmonary hypertension. Like other cardiovascular disorders, dyspnea, exertion, palpitations, and because high afterload states put stress on the right ventricle, right heart failure are the most common presenting symptoms of pulmonary hypertension. When cardiac output and cardiac index becomes compromised, syncope is a more later stage presenting symptom. And in more extreme cases, there can be local compression from PA dilatation. So, for example, there have been cases of left main compression, which we see a CT example here in angiography from PA dilatation. And there's also a risk of laryngeal nerve compression from pulmonary artery dilatation as well. Here's a nice algorithm that really helps me in my head go through the diagnosis and workup of a PH patient. Like with most cases, whenever someone comes into the cardiology clinic with dyspnea on exertion, the echocardiogram is the most commonly ordered test. And of course, we can estimate the RVSP with a TR jet velocity. However, there's a lot of clues on the echocardiogram which can steer the ship of how we work these patients up and further diagnose them. I really like to put a lot of weight in the left atrial and right atrial sides because this gives me a barometer of what the patient has been dealing with over a period of time. Of course, with the echocardiogram, we get the left ventricular function. We pay careful attention to the diastolic function. The tissue Doppler velocities, the mitral inflow velocities are very helpful in determining whether or not there is impaired renal action or diastolic dysfunction. I also like to pay attention to the valvular disease, as mitral regurgitation is a very dynamic disease and can cause a significant amount of passive left atrial hypertension. And of course, we pay attention to the right ventricular size and function, and even the pulse wave Doppler of the RVOT can give us some early signs if there is increased afterload in that circuit. If with all this information, even the clinical aspects, if there's HFpEF risk factors, or if depending on what the history is, this can really put me in a category of low, intermediate, or high pretest probability that this is related to left heart disease. In cases where the pretest probability is low, I usually would pursue to a pulmonary vascular workup, looking for PFTs, sleep apnea, doing autoimmune workup, looking for vasculitis if appropriate, and of course CTEPH if as this is often missed in pulmonary hypertension workup. So this is a common common occurrence when a patient gets an echo. You get a RVSP of 60 on the echocardiogram, and you have four very different presentations. On the top left, you have a 65-year-old with multiple risk factors for HFpEF, and the echo has many risk factors for diastolic dysfunction. This patient really does not need a pulmonary vasculature workup. They really need management of their HFpEF and substrate modification. And that goes for the same as the patient on the bottom left, where there's a 72-year-old with moderate to severe COPD requiring supplemental oxygen. The echo really doesn't have a whole lot, maybe a mild right ventricular enlargement, but this patient is most likely suffering from group 3 PH and just, again, needs optimization of his underlying pathology. As far as the two cases on the right, these really need a little bit more thorough workup and will benefit from further investigation. The right heart catheterization is required to make the diagnosis of the PH. So we have the echo, which raises suspicion, but we need the right heart catheterization to confirm the diagnosis. And this should really be done in a center that does vasoreactivity testing and is able to do provocative measures to unmask occult left heart disease in the form of exercise or fluid challenges. In our lab here, we use inhaled nitric. And for the fellows taking the boards this summer, a responder is someone who has a decrease in the mean pulmonary artery pressure of more than 10 millimeters of mercury with an absolute mean PA pressure of less than 40 without a drop in cardiac output. When we perform these baseline right heart catheterizations, these patients are usually in a fasting diarrhea state, which may underdiagnose occult left heart disease. If the pretest probability for left heart disease is high, and sometimes I use these scoring calculators, the HF2-PEF, the HFA-PEF scores, provocative testing may be useful. And this can be done in three forms. The most simple way is doing a passive leg raise in patients with a normal wedge pressure at rest, passive leg raise improved diagnostic accuracy for occult left heart disease with an area under curve of 0.82. And you're looking for an absolute value of over 18 millimeter mercury. To follow this, the patients can have a fluid challenge done in the cath lab. Again, this is easily done. We can bolus the fluid through the sheath. It's with the rapid infusion of saline with either 500 cc's or individualized approach of 7 milliliters per kilogram. And again, a cutoff of 18 millimeter mercury is diagnostic for occult left heart disease. A little bit more cumbersome and more sophisticated is doing exercise on the cath table. And this is done with a recumbent bike, which we have in our cath lab here at Robert Wood Johnson. Again, as I mentioned before, the absolute cutoff for exercise-induced pH is no longer used, but we rather use the mean PA over cardiac output slope of greater than 3, which is diagnostic for exercise-induced pH. And to further add to that, we plot the pulmonary capillary wedge pressure over cardiac output, and a value over 2 is diagnostic for occult left heart disease. So basically what we're doing is we take our baseline values and we have the patients exercise with the bike, and it goes through different stages of exercise, similar to a stress test. And at each stage, we record values and we plot them on a chart afterwards. And this is how we come up with these numbers. Next, we'll get into the different groups of pulmonary hypertension. I'll start off with group 1, PH, or pulmonary arterial hypertension. As I mentioned before, this is a rare, and the prevalence is estimated to be 15 to 50 cases per 1 million adults. And this can be further broken down into the subgroups of idiopathic, heritable, drug and toxin induced. And as I mentioned before, methamphetamines is a big player in this. And then pulmonary hypertension associated with other systemic illnesses. One of the big things being connective tissue disorders, scleroderma, which I'll highlight later, how its implication of pulmonary hypertension is very important on morbidity and mortality. Then you have congenital heart disease, portal hypertension, HIV, schistosomiasis, which is more of a developing world pathology. We don't see too much of that here, and thyroid disease. And if we break down the prevalence, idiopathic pulmonary hypertension takes up a big bulk. It's about 55% of pulmonary arterial hypertension, which is followed by connective tissue disorders and congenital heart disease. PAH is a very deadly disease. If left untreated, the median survival is about 2.8 years, with connective tissue disorders and HIV having the worst prognosis. I'd like to highlight the survival estimates on the bottom right here. This dark line, or the straight line here, is patients with scleroderma without PAH. And this dotted line here is the survival estimates for patients with scleroderma and PAH. As you see, this has a dramatic impact on mortality. And with this, in the guidelines, patients with systemic sclerosis have a class 1 indication to have screening for pulmonary arterial hypertension on an annual basis. And to add to that, in the rheumatology community, there's an algorithm used, which is called the DETECT algorithm, which is recommended to identify asymptomatic patients with pulmonary arterial hypertension. So a big player in the connective tissue disorders. And just to add to the PH prognosis, this is a modern U.S. PH registry. So this is in light of current background therapies. So we have 935 patients from 2015 to 2020. The median follow-up was about 489 days. And in this cohort, there was 121 deaths, so about 12.9%. And 1, 2, and 3-year mortality was 8%, 16%, and 21% respectively. So even with optimal treatment and modern day therapies, this disease is very carries a high mortality. We'll go ahead and move on and talk about the pathology of PH. So PH is characterized by fibrotic and proliferative lesions in the muscular arteries. It's characterized by vasoconstriction, arterial remodeling at all layers. So this includes the intima, media, adventitia, and formation of plexiform lesions where the intimal layer kind of sloughs off, the endothelial layer sloughs off into the vasculature, decreasing cross-sectional area, and small vessel thrombosis, all of which lead to luminal narrowing and even complete obliteration of small vessels. And to start out, these vessels are about 500 microns. And if we look at this illustration here, we have the top half, we have a healthy pulmonary artery, and in the bottom half, we have all these pathologic changes in which add to a narrowing of the cross-sectional area. Over on the right, we have some histology slides. This is a slide of slide B is a pulmonary vessel showing marked arterial narrowing with concentric laminar intimal proliferation and fibrosis. This is a slide of a vessel that has totally occluded, and these are the so-called slide D are the so-called plexiform lesions that we see. Here is a algorithm for how we treat these patients. Really, the goal throughout this course is to, or the disease process is to reclassify high and intermediate risk patients to a lower risk tier. So when we see patients without other cardiopulmonary comorbidities that with a lower intermediate risk profile, we start off with combination therapy with a endothelin receptor antagonist and a PDE5 inhibitor. The results of the ambition trial really push for a upfront dual therapy strategy. Whereas patients who are high risk, there is a push to start early prostacyclins, which most of the time are difficult for patient burden, as these are usually IV or subcutaneous. So patients have to walk around with a continuous pump. For patients with other comorbidities, a single drug stepwise approach is found to be appropriate. We'll take a second to go over the risk calculators. This is the 2022 ESE ERS baseline risk score calculator. And as you see, there's three categories. There's the low risk, intermediate risk, and high risk. And if we look at the 1-year mortality for the low risk population is okay, it's less than 5%. But as you see, if you go to intermediate and high risk, mortality at 1 year really jumps up to pretty high levels. So we look at these subjective and objective markers, and these patients get a point for whether it's low risk, intermediate, and high, and the average is taken for their risk profile. Here's the REVEAL 2.0 risk calculator, which some of us might be a little more familiar with. I like this one as well. This takes into consideration the WHO group, and also takes into consideration the PVR and the right atrial pressure, which is a little different than the ERS calculator. But all in all, same thing. We're looking at risk, and our goal in this strategy is to really reclassify patients as from high to intermediate risk and intermediate to low risk categories with treatment. Our traditional treatment pathways, when the endothelium becomes dysfunctional in pulmonary arterial hypertension, you have upregulation of the endothelium pathway, which leads to vasoconstriction and proliferation. And the two most common drugs that we use for this are ambrisentan and macitentan. Bosentan is not used as much anymore due to hepatotoxicities. And as far as the other pathways are concerned, we have downregulation of the prostacyclin and nitric oxide pathways. With nitric oxide, the two common used drugs are sildenafil and tadalafil. Tadalafil has a benefit that's once a day, where the sildenafil is a TID drug. Then we also have riociguat, which is a guanylate cyclase agonist. Both of these drugs induce vasodilatation and decrease proliferation. As far as the prostacyclin pathway is concerned, there's treprostinil, iloprost. Epoprostenol is not used as much anymore, but typically these are parenteral drugs that are administered through the subcutaneous or IV route. There are inhalation and pill forms of this, but these are a little bit newer and not as well tolerated. Selexipag is a prostacyclin analog, which is an oral medication. And again, with these medications, you're inducing vasodilatation and decreasing proliferation. And next, we have a new drug to the block. This is a sotatercept, which the results of the STELLAR trial showed that this is a new drug that we can use for group 1 pulmonary arterial hypertension. So sotatercept is a fusion protein acting as a ligand trap for TGF-beta, And inhibition of this pathway is proposed to rebalance pulmonary vascular homeostasis toward growth inhibition and proapoptotic signaling. The results of this trial show that there's a 34-meter improvement in six-minute walk distance over 24 weeks. Now, that might not seem like a whole lot, but if we look at the control arm here, there's actually clinical worsening. So not only did this drug prevent clinical worsening, there was actually improvement in functional capacity. Along with this, there was an improvement in the PVR, proBNP, and NYHA classes. And the results of the STELLAR trial granted FDA approval, which just is kind of hot off the press now, about a few months now. So this is a new drug that potentially has a role for impact in pulmonary arterial hypertension. Next, we'll move on to group 2 pulmonary hypertension. As I mentioned, nearly 70% of all PH cases will be secondary to left heart disease. And this includes heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, valvular disease, or any structural abnormality that causes a passive increase in left atrial filling pressures. The two subcategories, there's isolated postcapillary PH, which is characterized by a mean pulmonary artery pressure greater than 20, an elevated pulmonary capillary wedge pressure greater than 15 millimeter mercury, and a PVR less than 2 Wood units. And then there's a more complicated disease process with CPC-PH, which is the combined pre- and post-capillary pulmonary hypertension, which carries the same hemodynamic definition, however, with an elevated PVR with 2 Wood units. CPC-PH, the survival is quite abysmal, with estimates of less than 50% at 5 years. And if you look at these survival estimates on the right, we have isolated precapillary pulmonary hypertension, which is also not too favorable. And then we have CPC-PH, which is near the lines of precapillary pulmonary hypertension. We talked about how much of a burden that disease process has on morbidity and mortality. So we'll talk about CPC-PH and talk about the pathophysiology of how this disease process really causes its issues. So we start off with a process that increases left atrial pressure that's transmitted back to the pulmonary vasculature. And this can be attributed to a loss of left atrial compliance, diastolic dysfunction, mitral valve pathology, or even aortic stenosis. And over time, with continued congestion, there is endothelial dysfunction, similar to PAH, where there's downregulation of the nitric oxide pathway and upregulation of endothelium pathways. And then this is followed by diminished BNP-induced vasodilatation, and it leads to vascular modeling of both arterioles and venules in the pulmonary vasculature. And this all leads to pulmonary vascular disease, RV failure, functional TR, and altered RV-PA coupling. And we just showed the pressure volume loops, how you have the nice triangular shape that becomes a more of a rectangle with dedicated isovolumic relaxation and contraction phases. These are two histologies, two cross-section slides of pulmonary vasculature, and these look quite similar to the PAH slides that I showed earlier. But the patient on the left here has this is a patient that has PH due to left heart disease with a transpulmonary gradient of 30 millimeter mercury. And the patient on the right has idiopathic pulmonary hypertension. You see in the later stages, these two disease processes can look quite similar. So we talked about the burden of CPC-PH. Unfortunately, the use of pulmonary vasodilators haven't shown a large body of evidence in this disease process. And we look at the guidelines, there really isn't a whole lot of insight into how to manage these patients. A direct quote from the ERS guidelines show that, or states, the primary strategy in managing PH due to left heart disease is optimizing treatment of the underlying cardiac disease. And then to further add to that, they go on to give a class 1 recommendation where individualized approach to treatment is recommended. Again, not a whole lot of guidance and not a whole lot of information on how to treat these patients. And the use of direct pulmonary vasodilators has not really shown too much benefit, even potential harm in some studies. So we're really left with substrate modification in these patients. So for heart failure with a reduced ejection fraction, we look to optimize GDMT. If there's if these patients are appropriate for CRT, that could be a potential benefit. If these patients are truly advanced stage heart failure, we can offer mechanical unloading in the form of an LVAD. And we see this all the time for patients that have PVRs prohibited for transplant. We can implant an LVAD and offer the benefit of mechanical unloading where the PVR reverses over time. And HFpEF, again, not a whole lot that we can offer in regards to anything beyond maintaining euvolemia. There's a possible, SGLT2 inhibitors have shown some promise, spironolactone in certain patient populations have shown promise. And there's ongoing device trials. There's the interatrial shunt devices. There's a splanchnic denervation. And the results of the STEP HFpEF trial showed promise of semaglutide and functional capacity in HFpEF patients. And for structural heart disease, if the valvular disease is feasible to address, that can further help these patients. Here's a patient cohort of 51 end-stage heart failure patients with PVRs that are prohibited for transplant. And as we see this bar here with chronic mechanical unloading, we're able to really decongest that pulmonary vasculature and allow reverse remodeling and allow this PVR to come back down to a near normal level. The benefit of this is that some of these patients, which initially started off with a PVR prohibited for transplant, were able to be offered transplant in this trial and go on to successfully get that done. Then there's the interatrial shunt devices, where small studies have shown potential benefit in interatrial shunting to help unload the left atrial pressure. And this makes a lot of sense in a theoretical concept where patients who have normal resting left atrial pressures with exercise may have exercise-induced left atrial hypertension, which allows further shunting of blood to the right atrium. However, in the larger sham-controlled trial, this failed to show a reduction in heart failure events or improvement in quality of life in patients with a left ventricular ejection fraction of more than 40%. In addition, increased pulmonary artery blood flow remains a matter of concern, one may speculate. As far as these devices are concerned, there's other manufacturers and there's ongoing studies that certain phenotypes may benefit from this sort of therapy. How about a role for remote monitoring? As we all know, physical exam and home weights suffer from poor sensitivity and poor and reproducibility. And quite frankly, when we wait for weight changes and symptoms, these patients have already decompensated and is a late manifestation of decompensation. We really want to catch patients here in this early filling before they become symptomatic, where filling pressures are still acceptable and before they increase and cause other issues. And as we all know, chronic monitoring of filling pressures via right heart catheterization is not feasible due to a variety of logistical reasons. So this brings up the topic of remote PA monitoring. As we all know, hemodynamics are the most important piece of pulmonary hypertension management, but not readily obtainable. And that brings up the topic of implantable PA sensors, most notably the CardioMEMS, which there are other PA sensors, but this is the most commonly used device on the market. So for those of you that are not familiar with the CardioMEMS, this is a small sensor, about 4 centimeters large. It's delivered into the pulmonary artery via over the wire technique. Basically, you float a swan up into the distal pulmonary artery. We feed a wire, and over the system, we deliver this small sensor. This is what it looks like under fluoroscopy. We have the balloon included. You have contrast injection. And you look for a good landing zone. And when the patient is implanted, they go home and they lay on this looks like a pillow, but there's really a sensor which transmits data to the clinician. And this is what the workstation looks like. So you get a reading of systolic, mean, and diastolic pressures. And hopefully the trends look like this, where you start off with high pressures and with aggressive diuretics and finding a good algorithm that works for a patient, you can find a good happy medium where the pulmonary pressures are adequate over time. And the use of this product was supported by the Champion trial, which enrolled NYHA class 3 patients irrespective of left ventricular ejection fraction. Over a 6-month follow-up period, remote monitoring led to a 37% reduction in heart failure hospitalization. And the freedom from device-related complications was 98.6%. So overall, a pretty safe procedure and pretty safe device. Next, we'll move along to group 3 pulmonary hypertension. This is frequently observed in COPD, ILD, and hypoventilation syndromes. This is the second most common group of pulmonary hypertension after left heart disease. And group 3 PH is really broken down into severe or non-severe based on the PVR cutoff of 5 Wood units. In COPD, severe PH is observed in 1 to 5% of cases. In ILD, this is about less than 10% of cases. And as far as therapeutics, the use of systemic pulmonary vasodilators is limited due to the theoretical risk of a worsened BQ mismatch. As you know, hypoxia is a potent vasoconstrictor where we try to shunt blood to healthy lung, if you will. So the theoretical risk of opening up areas of perfusion to lung spaces that are not well ventilated can worsen hypoxemia. So we'll talk about PH-COPD. Like I said before, pH-specific therapies for COPD and emphysema yields conflicting results, and this is mostly due to the small sample size and short duration of follow-up in these studies. In the guidelines, PDE5 inhibitors may be considered on small registry data and severe pH-related COPD. And recently, we had the results of the PERFECT trial. This was just published about a month ago, where inhaled treprostinil in PH-COPD was tested. Unfortunately, this study was terminated early due to increase in adverse events. For PH due to interstitial lung disease, again, ERAs and PDE inhibitors have really yielded negative results. And there's actually a signal towards adverse safety events that were noted with the ERA and ambrisentan. And riociguat, there was a potential excess in mortality. However, the results of the INCREASE trial showed that increased treprostinil in ILD-PH improved 6-minute walk distance by 31 meters. Again, not an impressive distance, but if we compare it to placebo, where there was clinical worsening, this drug actually prevented clinical worsening and improved walk distance, pro-BNP, and clinical worsening. Due to the results of the INCREASE trial, which is about 2 years old now, this drug has gotten a 2B recommendation for ILD-related PH. Next, we'll talk about group 4 PH, or we most commonly refer to it as CTEPH, or the new terminology that they use is a chronic thromboembolic pulmonary disease. So these are symptomatic patients with mismatched perfusion defects on BQ scans and with signs of chronic organized fibrotic clots on CTPA or digital subtraction in the cath lab. That is persistent after 3 months of anticoagulation. PH is a consequence of PA obstruction and associated microvasculopathies. Fortunately, in CTEPH, there are both surgical and medical treatments that are approved. Pulmonary endarterectomy is a treatment of choice, which may even normalize hemodynamics. Some studies report a 65% reduction in PVR. The persistence of post-op PH is quite low. It's about 25%. And the 5-year survival is reassuring too, with 83%. And this beats the alternative of patients with CTEPH that are not operated on with the 5-year survival of 3%. Riociguat is the only medication approved for inoperable CTEPH or persistent PH after pulmonary endarterectomy. And for patients that are inoperable candidates, the balloon pulmonary angioplasty is also indicated. And this also has reassuring results with a PVR reduction of 49 to 66% observed. However, the long-term data on this is scarce at the moment. Here we have 2 examples. This is on this slide, we have pretty much a stump of a pulmonary artery that is intervened upon with angioplasty. As we see, there's reconstitution of distal flow. And here we have a cast. This is what the patients look like that undergo PTE. We have a perfusion scan, which shows pretty much blackout of this segment of lung. And again, we see a stump here and a missing segment on this side. Now with pulmonary thromboembolectomy, there's reconstitution in the VQ scan, and and unfortunately, not a repeat angiography there. As far as future therapies in pulmonary hypertension, right now the Trophy 1 trial, which tested pulmonary artery denervation in a small patient population, about 23 patients, showed a 17.8% PVR reduction with increase in 6-minute walk test. And this trial is ongoing with a larger population. So I really look forward to seeing what the outcomes of that are in terms of future therapies in PAH. As far as the interatrial shunt devices, I mentioned earlier that the larger sham control trial yielded no benefit. However, a subgroup was identified. So this is going to be studied in certain phenotypes to see if there's benefit in this population. Another HFpEF trial around the corner. There's a spinal nerve denervation. Again, this is just addressing the stress plasma volume with the HFpEF cohort. And now that we have a new pathway with sotatercept, which is not really a pulmonary vasodilator, it just kind of addresses pulmonary remodeling. I hope that this will be tried in PH left heart disease and the PH group 3 PH cohorts as well to see if there's any benefit in that population as well. As far as conclusions, as I mentioned earlier, 70% of pulmonary hypertension is related to left heart disease. Regardless of cause, modest elevations in PVR and pulmonary pressures increase morbidity and mortality. As far as right now, as far as the guidelines and the data that we have at this moment, the routine use of pulmonary vasodilators in non-group 1 PH patients is not recommended. And with the current guidelines, with the current updated guidelines with the lower PA pressure and the lower PVR, these values inform us of risk in regards to morbidity and mortality. But treatment trials were done at higher thresholds, so this would require further research into seeing what patient cohort will really benefit from these vasodilators. And like I mentioned before, the seventh World Symposium of Pulmonary Hypertension will take place next month in Barcelona. So I really look forward to seeing what are the latest updates and these latest updates in this patient population that carries a significant morbidity and mortality risk. I'll stop there.
Thank you, Jagpreet, very much for your very comprehensive coverage. And looks like we will see if you can unshare your slides, then we'll be able to bring back people in a spotlight mode.
See if I can.
Yeah.
Sorry.
And then we will have Dr. Kenneth Delnawan.
Here we go.
There you go. So,
hey, Dr. Grewal, thanks for that very thorough, very excellent presentation. Just two practical questions. Number one, now that they keep on lowering the threshold to make the diagnosis of PH, the more reliant are we in getting accurate numbers? That being said, when you measure your TPG, do you always measure it at end expiration, or are there any cases where you actually use an average or somewhere different in the respiratory cycle? That's one. Second, if you have an EDP, if say, for example, the patient got a left heart cath and you have an EDP measure, do you use that to give your calculation? Because as you know, a lot of these things can make or break, the diagnosis of PH as opposed to just post-capillary pulmonary hypertension. That's my first question. Second question, with the advent of all these like new therapies, do we still have to do vasoreactivity testing? Is there still like any role for high dose calcium channel blockers, which, as you know, it takes forever to do that test?
Yeah. So I'll answer the first question about measuring transpulmonary gradient. So typically I like to be consistent with my measurements, and wherever I'm measuring the mean pulmonary artery pressure, I like to stay consistent and get that at the end expiration for both mean PA pressure and the wedge pressure. Sometimes in the cath lab, it's not perfect to do that because there's large swings. Sometimes patients have large V waves. So I try to stay consistent and measure the by bisecting the A wave at end expiration, because that technically should be end diastole, and report that value. Now, if there's situations where there's a large V wave or it's about 10 to 20 millimeter mercury more, I typically try to report that as well because the pulmonary vasculature also experiences that surge of pressure. So that was your first question, and then the second question about vasoreactivity.
If you have an EDP, would you use the EDP in lieu of your wedge?
So the EDP is valuable. Of course, there's a handful of disorders that can cause a discrepancy between your wedge pressure and your EDP. So I put a lot of value in that, of course. And the as far as the question about vasoreactivity, so what I didn't share was these patients have one for PH, you're taking a rare disease, and there's even a smaller subset that is vasoreactive. So maybe like 10 to 20%. So we're looking at a very small subset of these patients. Now, to add to that, these patients do have a better prognosis. They respond to calcium channel blockers, but the sustained benefit is also limited over time. So I still test for vasoreactive because it informs me of the prognosis. And although the benefit is not sustained over time, I think it's important to know the prognostic information.
And in light of what was being asked, Ken, when you mentioned about the LVEDP and diastolic pressure, I mean, I'm just coming from my comprehension from how we are, at least in echocardiography, trying to measure the filling pressures. So what we found, at least the indices, echocardiographic indices of LA pressure, of wedge pressure, mean pressures, are closer to pre-A pressure of the LVEDP than the LVEDP, because you can have a situation where the LVEDP is elevated because of a stiff ventricle, but the mean LA pressure is not elevated. So so I've also seen that. But in that light, Jakpreet, how often you like to go for an LA pressure? Or have you ever had a situation where you say that let's do a septal puncture, and because that's ideally the pressure that you're looking for, the filling pressure on the left side, but you're interpreting it from the wedge pressure. Or in other words, in what circumstances you think the wedge pressure becomes unreliable?
So in cases of, I mean, it's quite rare now, but class teaching of pulmonary vein stenosis in patients with recurrent AFib ablations, I've had a couple cases in training where we've actually measured a gradient across a gradient from the wedge in the direct LA pressure through a direct septal puncture. Now, I that's only like a handful of cases, and I think it's a little bit easier to get an LVEDP in cases where the wedge is not reliable or just not doesn't have good reproducibility. Well,
yeah, I see a hand going up. I think Dr. Albert wants to. Joni, feel free to unmic yourself and ask the question if you want to.
Hello, great presentation, Dr. Grewal. I really enjoyed it, and thank you for the comprehensive overview. One of the challenges, one of the struggles, and you already highlighted this, was how do we manage combined pre and post capillary pulmonary hypertension, or CPCPH? And you highlighted that, even PDE5 inhibitors, which we use sort of as like our first line therapy, is somewhat contraindicated in this patient population. And unfortunately, as advanced heart failure docs, a lot of our patients, have this combined pre and post picture. And, at various times we'll see an elevated wedge, or, with aggressive diuresis, you see the wedge normalize. But, how reliable is that? And what would you recommend as far as medical management? I know you mentioned some other sort of GDMTs that we could consider, but if you could, for example, do a clinical trial in this space, what agent might you choose to kind of test out in this patient population?
So, at ISHLT last year, I sat in on a talk by I believe I think it was by Dr. Benza, where he mentioned that a lot of these trials with pulmonary vasodilators are done in a fashion where the left atrial pressure is not really accounted for. So these trials don't really are not focusing on decongesting patients and then trying pulmonary vasodilators in a stepwise fashion. And I think there's a benefit in that. Like you mentioned, some of these patients that are being worked up for transplant or advanced therapies, we try to diurese them, and the TPG is still high, and then we try pulmonary vasodilators on top of that. Now, the theoretical risk is that you're opening up pulmonary vasculature that will allow higher flow to the already stressed out left atrium and induce pulmonary edema. Now, when we do this, we do this in a safe manner where the patients are seeing us quite often. We're getting routine right heart catheterizations, and we try to make a conscious effort to keep the wedge as low as possible and allow remodeling. Now, you mentioned as far as a trial, I think sotatercept brings up an interesting angle on how we address CPC-PH, because this is not a pulmonary vasodilator. It's really addressing the those degenerative pathways that cause vascular remodeling. If you look at the trial data, even though the PVR went down, the cardiac indices remained the same. So that's kind of the opposite of what we see with pulmonary vasodilators, where everything gets opened up and you have higher flow. So I think that would be an interesting concept to try out in these patients.
That's great. Maybe we can bring that clinical trial on board, and you can be the national PI, right? Thank you.
Thank you.
Ken, any other questions from your side?
Yeah, just one last question for Dr.
Yes.
Graywall. Dr. Graywall, now that you're building our pulmonary hypertension clinic, what do you see as the biggest challenge in making this clinic successful?
So I think, as I mentioned before, there's a lot of different specialties that have a hand in pulmonary hypertension. And for example, rheumatology, I went over the slide where the survival estimates are vastly different in patients with scleroderma and scleroderma with PH. They're pretty much night and day differences. So I think early detection from, where we have a scleroderma clinic already established, having those patients be routinely plugged in, I think that's going to be a big factor. And we also have a ILD clinic. I think having these patients present more to our clinics and kind of have them plugged in earlier with us will be a good step in building that PH practice here.
Thank you. There is someone trying to ask a question. I cannot say who it is, but would you be able to announce your name and ask the question?
Hi, Dr. Graywall. Thank you so much for this fantastic
Dr.
talk.
Maganti.
This is Kamu Maganti. I posed a couple of questions in the chat. If you could just read them and maybe answer.
Let me see.
It's not come through.
Yeah, I don't see it.
Oh.
So do you want to ask these questions now?
I was just going to ask you, RV-PA coupling as well as multiple RV measurements based off echo that we typically do can be very challenging, especially in dilated right ventricles.
Mm-hmm.
What are your thoughts? And then the second thing was, it was really thought-provoking to listen to the mechanical unloading in WHO class 3. And I didn't know if you meant RVAD or VB ECMO in that population. So these two questions.
So the last question was for group 2 PH with left heart disease. And I'm talking about LVADs.
Oh,
so,
I see.
Yeah,
you
so
meant
basically
group
the concept
2,
is
not group 3.
Group 2, yes.
Okay. That
yeah,
makes
so
sense.
So with LAD compression, over time you can have reverse remodeling. And we see that often with our patients. Even within a span of 3 months, we're seeing our LVAD patients from November who had PVRs prohibitive. They're now acceptable for transplant. And so the first question, I didn't get that.
Oh, the first question about all the multiple RV measurements in dilated RVs, especially the RV-PA coupling, as well as even TAPSE, even S prime. in very dilated RVs because the RV dilates in a really funny way, right? So these measurements are very, very difficult, not only to obtain, but also you don't know exactly where we are measuring some of these measurements. And I don't know what your thoughts would be on looking at the coupling intervals and stuff like that.
Yeah, it's I don't have a great answer for that one, but yeah, so when with TABC and RVS prime, all these measurements that we use, even RV strain, you're really dependent on the quality of the image acquisition. And yeah, I agree. When the RV dilates to a certain, the whole RV or even the biventricular dilatation, you lose the quality of those measurements. But as far as measuring coupling from a non-invasive standpoint, I'm not too I don't have a good answer for you on that.
Well,
And- yeah.
thanks again, Japri. This was
Yeah.
fantastic.
Oh, thank you.
Great. If there are no other questions, I'd like to thank you, Jakpreet and Kenneth, for joining in, and for all of you. And I wanted to just make announcement for the next grand rounds that is on the 10th. We have a slight shift. The grand rounds is going to happen from 3 to 4 p.m. and it's in person in the CAB building. Please mark your dates. Marty Leon is going to come and give us talk. And this accommodation is in lieu of the fellowship and residence graduation date that coincides with the same date of the grand rounds. So please make the note of the change of the time, and it's an in-person Marty Leon on 10th June, 3 to 4 p.m. With that note, I would like to thank everyone and look forward to seeing you all in the next grand rounds. Thank you very much.